All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today we have with us, I think you would really, really, really enjoy her presence today. We have an allergist, immunologist, and a person who has been working on vaccine research. She's part of the vaccine research, and she's part of the long COVID management with Dr. Bruce Patterson and Dr. Yo's team. Again, full disclosure, I do not have any commercial or financial or otherwise interest with the Dr. Patterson and Dr. Yo's group. My interest is to bring in folks here and they can share their knowledge with the cool beans, and that is what is what we get from this. So we have Dr. Purvi Parikh with us. She is a rock star of this area. She is a leading physician helping with this long COVID especially. So Dr. Parikh, welcome.
Thank you. Thanks for having me.
So right now we have a lot of folks who are live with us. We would be watched afterwards separately too. So for the program structure, I would request your introduction, and after that we would go over the COVID management. After that, we would open the forum for live questions as well. We'll take some questions on the Twitter side too. So cool beans, please, if you can do me a favor for 15-20 minutes, if you can hold on to your questions, because they would just scroll up and disappear. And then after that, please start writing the questions with the letters QQQ with them so I can identify them and request them. So once again, with that administrative talk, Purvi, thank you very much for being here. Tell me a little bit about your day-to-day activities, professional activities nowadays with pandemic.
Right.
What changed?
Yeah, it's definitely changed. I'm still, an allergist and immunologist, so I still see all the bread and butter allergy and immunology cases that we would see before the pandemic. So I treat everything from food allergy to environmental allergy, drug allergy, even rare things like, mast cell activation syndrome, asthma, and I also treat people with underfunctioning immune system. So a whole entity of disorders called primary immune deficiencies, which there are 300 of. So all of that I did before the pandemic, I'm still doing now. But because of COVID and because of the importance of immunology and infectious disease, I became very interested in COVID research, how to help, move us out of the pandemic. Because like many of us, this is completely life-changing. And, we, at the beginning, especially felt very helpless, especially I was being in New York the first 3 months, just seeing so many people dying, people I knew personally getting sick or passing away from COVID-19. So I started getting involved in the vaccine research in May of 2020 when we at the NYU Vaccine Center started doing the studies in Pfizer, AstraZeneca, Sanofi. I'm still involved. Now we're actually doing those three. Plus, we're also looking at a study in pregnant women and monitoring them, when they get the vaccine, when they're pregnant, when they deliver, and we're following their children, because many questions that people have is, what are the long-term effects? What is the safety? What is the efficacy? And doing research is how you can safely and effectively get this out to the masses. So we're working on that. And so that's taken up time, which I wasn't doing before. And I'm, kind of trying to educate the public, because as we know, there's a lot of misinformation out there too. So very frequently on a day-to-day basis, I will, do talks like this one. I'm, very involved in the media to give COVID updates based on the new research and what's changing. And, I try to keep people as updated as possible because things are very confusing and they're changing. And then also for the past year, I've been involved with Dr. Patterson and Dr. Yogendra in their research with the COVID long haulers, because, so much is focused on the people in the hospital, right? Or the people passing away, that we're missing the millions now who are recovering from COVID-19 and they're really struggling, and I think we're going to be seeing this for years to come. So I think this is a very, very important place to research, because these people who were completely functional, healthy, active before they got sick now can't work, they can't go to school, they're having very, very troublesome symptoms. So I'm happy to be part of their group too, to hopefully, help them feel better and try to understand why this is occurring. And this is a hot topic of research, not just with us, all across the country. Now, every major academic center is shifting towards long haul research. I think that's the right thing to do.
Very, very interesting. Thank you very much for this. And I am actually quite surprised with the SARS-CoV-2's capabilities and the way it has been, the kind of symptom set it is creating, and it is changing with those symptom sets, and then the long haul effects that it is creating is, considering other coronaviruses, where we used to read one paragraph about a coronavirus and be done, considering those kind of coronaviruses, and here we have a SARS-CoV-2 that is such deep and devastating virus. Tell me this, with your research, have you gotten any indicators to say this is why it is such a devastating virus?
Yeah, that's a great question. I think a mystery that almost everyone I know in medicine is scratching their head about. Like, why is this? I know doctors who've been in practice 40 years that say they've never seen anything like this. And I mean, you can go by the fact that our immune systems just are not used to it, right? And it's something that we don't know how to process. It's a brand new virus, but we didn't see anything like this with the other SARS viruses, right? In the early 2000s, with SARS, MERS. We even had the H1N1 pandemic about 10 years ago. Then, I was in residency at the time, and that's when I kind of had my interest in these type of things and in vaccine research. And we didn't see anywhere near this type of devastation. So it's very interesting. And I think a lot of research still needs to be done to show why some people have zero symptoms and some people are at, death's door. And it can be, there's no rhyme or reason to it. So initially we thought, oh, it's all elderly people with medical chronic comorbidities. Then we realized young and healthy people were also getting very sick and dying, and then we thought, okay, well, at least children are spared. But now with the new variants, we're seeing children get very sick too and ending up in the hospital in the ICU. So this virus, this coronavirus, for some reason has found a way to really, trick our immune systems in ways we've never seen before, right? Causing blood vessel inflammation. And Dr. Patterson, I know, has spoken about that, both in the acute and chronic phases. All the clotting disorders and everything else that comes with it, causing neurological issues, lung damage, heart damage, kidney damage. So it's crazy. And I wish I had a good answer as to why, because then if we had the answer, we could tell you how to get rid of it, right? Or the appropriate treatment. But it's just such an evasive virus to the point where not even there's a one size fits all treatment either, so some things that work really well for one patient don't work at all in another. And that's another thing we don't understand. So there's many, many questions. As we find the answers, more questions come,
Absolutely. And thank you very much for doing these researches. It is fascinating for me to see that one virus with this specific spike protein and its interaction with the ACE2, I mean, at least on the surface, that is all it is.
Right.
And that such a broad width of issues. So thank you for continuing that research, and we'll keep requesting your presence so that we can keep asking more of these questions and getting your insights. Now, tell me this, from a vaccine research point of view, I want to go to the COVID discussion,
right.
But I want to ask, you have some very interesting credentials. So the vaccine research, on the vaccine side, what is the primary focus for the research, or what are the big concepts in the research that you are looking at? Is it that current vaccines, or could we have different kind of vaccines, or how the current vaccines are working? What is the how do you see the research going? What is the research?
That's a good question. So, it started out initially, let's get a vaccine, that's hopefully safe and effective, and that will reduce the chances of severe COVID-19. No vaccine, I just want to state this, is a cure. The whole point is the vaccine is supposed to save your life and keep you out of the hospital. So that was the first goal. But now with new emerging variants, and people breakthrough infections and these variants more contagious, the pivot now is, are the vaccines effective against the variants? And do we need new vaccines, as you mentioned? Do we need to change the existing vaccines? Do we need a booster of the existing vaccines? So this is where all the research is currently. It's focused around these new variants and to kind of predict how we can get ahead of future variants, right? So being more proactive based on now what we know, because we were kind of caught unprepared in general, this whole pandemic. But now that we're understanding the variants and how to hopefully dodge them, that's where the research is heading now.
Got it. Thank you very much. A few days ago, I had done a talk in which one of the cool beans, his name was Day, I remember it very clearly. He asked a question that was fascinating. And his question was, if we can, I'm paraphrasing, if we can understand how the virus is eventually going to stick to ACE2 in its best sticking form, for
Right.
example, could we start preparing ahead of time a vaccine that would beat its future changes and improved fit? So, is there a way that a new vaccine could be developed that could get ahead of the further changes in the virus?
Yeah, absolutely. And that would be the ultimate goal in my mind, So even with the current vaccines, each vaccine targets a different portion of the spike protein, the different parts of the receptor. So Pfizer targets a part of it. J&J, AstraZeneca work in a different way in that they have a inactive virus that brings the information in. But if we can get to the point where we can anticipate how that protein is going to bind to the receptor and just prevent the binding altogether, that would be huge, right? Because then even those milder and breakthrough infections may not occur. How we can get there, I don't know. Maybe your Cool Bean will be the bright scientist to get us there, but that would be the ultimate goal. So that's a great question.
Got it. And Dave, if you're hearing, your question was fascinating. It still is fascinating, and I think it's going to stay a focus for the research as well. Another question around the vaccine research and the vaccines themselves. Do you think that, so this is where I have less data available, inactivated virus versus spike protein vaccines?
Mm-hmm.
And this is a very common question as well. My thinking from reading articles is that inactivated virus vaccines were supposed to be better because they create a broader spectrum of antibodies. However, the data is not emerging that shows it is better than the spike protein vaccines.
Right.
Do you have more data to say one is better than the other or equal? What is your...
That's a great question. Yeah, and I get asked that a lot. Which is better? Which one should I take? So it's very hard to use that word unless we do a study where they're all compared head to head at the same time. And the reason why is because the spike protein vaccines were studied, right, and approved, emergency approved, before the variants were in circulation, right? And then J&J and AstraZeneca, their results came out while the variants were circulating. So it's like apples and oranges. It's hard to say that, this is less effective. Maybe they would have had similar efficacy if they were all studied at the same exact point in time. So one, I would need a study to happen where they're all compared what we call head-to-head in medicine, so that, equal number of people get Pfizer, Moderna, J&J, AstraZeneca, and then we compare them all and see what happens, and Novavax, right? And then we can really say this one is better, this one is better. But one theory that I have about the vectors is that, because you have a vehicle bringing the information into your immune system, there is a chance that with the second dose, like with AstraZeneca, it's a 2-dose vaccine, that your immune system then may recognize that vector, and rather than only reacting to the information about the virus, your immune system may also start reacting to the vector itself, making it a little less effective. Russia, it's very interesting. They use a vector vaccine similar to J&J and AstraZeneca, but theirs, at least based on their data, is more effective. And I think the reason is they use 2 different vectors. So they use one type of adenovirus vector for dose 1 and then a different one for dose 2. And I think that may help the immune system have a better response because you're constantly keeping the immune system primed and on its toes. So, once the immune system gets used to something, it may not have as robust a response as you would expect, So that's my own personal theory. And that's why I think Russia's vaccine may be a little more effective. And maybe in the future, we may need to mix vaccine platforms just to keep our immune systems on their toes, so to speak.
Totally agreed. And I discussed the Sputnik vaccine and how they use adenovirus 6 and 20 something as well. And one is the one which is most prevalent in us and the other one is not. And so
Right.
that is a beautiful mechanism. And you are absolutely correct that it is possible that tomorrow at some point, the vaccines are going to be cocktails instead of just one, here is a spike protein vaccine.
Right. And I think that would be very helpful too,
Yeah. So tell me this then, one last question on the vaccine and then we go to COVID. Tell me this, there have been some vaccines for, let's say, Purvi, you there? your your net became. Purvi, you there?
Oh, hi, Dr. Mobeen. Can you hear me?
I can hear you, but I
Oh,
cannot see you.
okay, there we go. Okay, sorry. My
No worries.
screen froze for a minute, so I apologize.
Yeah,
Go
no
ahead.
worries.
I missed the last point you were making.
Yeah. So the last point with the COVID, is this possible to come up with the vaccines? And I know that there are various trials that are going on
Mhm.
that are more oral or nasal sprays that are more IgA developing vaccines to
Mhm.
strengthen our barriers. Is this even a valid concept? Should it
Right.
be done? Is that kind of a vaccine an important step as well, or maybe not?
Yeah, I mean, I think so. So already there's a nasal formulation that is being looked into, and it has very promising results. The issue with the nasal and oral vaccines is sometimes what we call the systemic absorption may not be as good as with something that's injectable. But the one benefit of these localized vaccines is that it can, as you mentioned, create that local immunity and hopefully stop the virus right in the nose, right, or right in the mouth before it can move deeper into the airways. And so I think there is benefit there. It could be used as an add-on, right, because the nasal spray is so easy to do. Anyone can administer it. It's easy to distribute it to the masses. So it could be something where you get it while you're waiting for the official vaccine dose, because as you know, majority of the world has no access to the vaccine, especially third world countries. It's very low vaccination rates. Or it can be like an adjunct to the initial vaccine. So far, the studies don't show that it can be a replacement. Even with our flu vaccine, we had nasal alternatives in the past, but then the CDC ended up finding that, it's not as equivalent in terms of immunity and efficacy. So, but I think there is a role for that because IgA is extremely important in upper respiratory infections and clearing them from your nose and lungs. So absolutely, either as an add-on or if we have the data, maybe one day we'll have those type of local vaccines even be another alternative for people who don't want the shot.
Got it. So that's very interesting. That means taking your various points that you're making, that means it is possible to have a cocktail of vaccines, which may be further cocktails of vaccines. That is, we have nasal vaccine plus injectable vaccines, or maybe oral vaccines. And
Right.
then those that are injectable, they themselves are the cocktails of maybe spike protein and the inactivated virus. And so that whole structure together acts as the best protection possible. Is this something possible?
I think so. And maybe this might be a key in the future to the variants, right? Because if we can find a way, so let's say we find that, the Pfizer shot I got 8 months ago is not as good with the Delta variant, right? But then if I can take a nasal vaccine that might stop that virus right in my nose, that would be great, right? So then we don't have to may not have to go to another booster shot. Maybe we can work in conjunction and get the IgA immunity up to par along with our IgGs. And T cells and other things that the shot helped activate.
Got it. Got it. Thank you very much. So now I'm going to switch gears towards the COVID management. So usually the structure for the COVID management we do is we talk about prophylaxis, if any at all, that you have tried or you believe in. Then the acute disease management, in hospitalization or in hospital management, and then long COVID. And please comment wherever you feel that you want to add more value. So first of all, starting with the prophylaxis.
Mm-hmm.
In general, day-to-day life, how do we become better protected? What is your advice?
All right. So the simplest thing, day-to-day life, let's start with that, is how you live. Healthy lifestyle is still extremely important. I know there's so much talk in general about therapeutics and vaccines and all of this, but if you look at the numbers, even though, yes, young and healthy people do fall ill, they do get sick, there's still an increase in morbidity and mortality if you're obese and overweight, if you have heart disease, if you have diabetes. Those are the three, biggest conditions. And many of those come, not always, but many come from unhealthy lifestyles, right? Or lifestyle changes that can occur to make those illnesses better under control. So the best thing you can do for your immune system on a daily basis, before we even get into anything further, is make sure you're getting adequate sleep. I've seen, sleep, many studies have shown affects your immunity, both cellular and humoral. Make sure you're eating a well-balanced diet. And this even goes into my realm in the allergy world too. All the processed foods, junk food, alcohol that the Western culture is consuming is not only impairing your immune responses to fight infections, but it's actually making us more allergic, causing more autoimmune disease and more cancers. Now the colonoscopy screening guideline has been reduced to age, I think 45 or 40 because of lifestyle. 100% lifestyle changes. We're seeing more cancers because of these foods. And those same processed foods, junk foods, can disrupt your gut microbiome. And as a result, even we can see increases in allergic diseases as well. It's all part of this hygiene hypothesis. So in some ways, we can't be too reliant on these chemicals and being too clean, because it's actually doing our immune systems, our microbiomes, a huge disservice. Overuse of antibiotics as well. We're disrupting all the good flora and bacteria within us. So that's first and foremost. And then in terms of all these things like supplements, it's so confusing. I don't blame patients that, there's all this advocacy for high doses of vitamin C or D or zinc, but in studies, purely evidence-based, the only vitamin that really makes a key impact on your immune system is vitamin D, like dog. And most of us are low, myself included. I take vitamin D supplementation. Most of us should. Now, do you need mega doses? That's something you need to discuss with your doctor, because it really depends on your blood level. If you have a very, very low vitamin D, you may need a higher dose than the over-the-counter one. Zinc is another important one for your immune system. But the good news is that at least in America, most of the Western world, we have enough zinc in our diets that you don't have to supplement. Where I have seen people really struggling with zinc deficiency is if they're from a part of the world where they're malnourished, they don't have enough access to nutrients, things like that, then it really can impact your immune system. And that's without doubt. But again, a lot of the mega doses people are taking, there's no real good evidence behind it or structure behind it. So those are just kind of lifestyle things. And then moving into, prevention, I am a vaccine researcher. I study the data. So I am a big proponent of the vaccines. I think it's the single most efficient immune booster that exists. And no infectious disease in the history of time has ever either been eradicated or reached herd immunity without a vaccine. And that's a fact I just learned during this pandemic. So we need them. They do work. And I know that has become a controversial opinion, but that is one of the best things you can still do in prevention, right? And then that's what all of us doctors like, is prevention, because then you don't get to the point where you need these aggressive life-saving treatments. And then in terms of other prophylaxis and early intervention, I am a big fan of the monoclonal antibodies as well, that President Trump received and now other patients are receiving, because they have shown, especially if you're someone who can't get the vaccine, it can act like a passive vaccine that works immediately for you if you happen to get sick. And we're even looking at it in people before they get sick. So let's say I live with someone who has a COVID infection, and I haven't been vaccinated, or I'm high risk for some reason because my immune system's compromised. We're now looking into administering it to those close contacts and those family members to protect them. So I think those monoclonal antibodies are underutilized in early infection and also underutilized in prevention for those people where the vaccine may not be an option for some reason. So for all of those reasons, and there are many individuals who get the vaccine and still don't mount an immune response because they're cancer patients or the immune deficiency patients that I treat. So these therapeutics are very, very important. Plaquenil and hydroxychloroquine, we looked into that early on. Unfortunately, the studies, in my opinion, were kind of stopped short in preventing the infection. We even were treating people with it early on. I was, as an outpatient doctor, before we had the studies, we were giving it inpatient. It was part of almost every academic center's protocol for sick patients coming of COVID. Sadly, it didn't help, And ivermectin too now, I will admit it does have stronger evidence than Plaquenil in, prevention and early intervention. But in my opinion, it's not enough as a standalone. You still really need the vaccines or the monoclonal antibodies. And that's just fact and evidence-based. I wish it was enough because it's a cheap drug, it's easily accessible. We've seen great results in our long haul patients because it is a great anti-inflammatory. I myself use topical ivermectin for my rosacea, so we know it stops inflammation, but we have to use it in the right way, if that makes sense. And then, of course, I mean, I'll stop there. I can go deeper into the hospital, ICU, all that, but I'll stop there and let you intervene.
Thank you. And we're going to go to those points as well.
Yeah.
So this is interesting. An important point that you have added is the monoclonal or to Regeneron, which is kind of polyclonal, two and monoclonals.
Yes. Yeah.
And I had seen that, look, in case of, for example, Giuliani or Trump, I thought that with their age, they had some risk factors. And then, and I may be wrong, I'm just speculating at I think they got Regeneron and that worked miracles.
Yes.
So you're very, very correct that if somebody is at risk, is not vaccinated yet, then these polyclonal antibodies should be, or monoclonal antibodies should be something to be looked at.
Yes.
Very good. Thank you for this. If I continue to the next phase, so this is the prophylaxis or staying healthy and staying protected. How about if somebody got, so if I come to you today and I say, you know what, I have the symptoms, PCR is positive, how would you manage me or manage a patient?
Yeah, and I'm sorry, I think I jumped the gun because I started talking about the monoclonals. They are helpful in prevention, absolutely, and they're being studied that way now, but they're most helpful once you're sick already. So let's say even if I got sick today, I'm fully vaccinated, but if I started being sick and feeling symptoms, I would want to get the monoclonal for myself. And that's what I've been recommending now. So my patients who come in, they say, I'm positive, I have fever, cough. I say, okay, we have to get you this monoclonal treatment ASAP because timing is key. If it started within the first 72 hours of symptoms or the positive test, it works significantly better. And it keeps people out of the hospital, even in hospitalized patients, there is some benefit, but the biggest benefit is out of the hospital. And those patients in mild and moderate, please, if you get sick, take it immediately. Other things.
Sorry for the interruption. My apologies. This is a very important point you're making, and I want Cool Beans to be aware of it. How do they talk with the doctor about it? What do they ask them? If the doctor is, let's say, not aware, I'm sure that doctors are, but let's say if they're not, what do they go and say? Should they say, I need Regeneron, or what is the communication?
Right. So the communication should be, I'm sick with COVID-19. I'm positive. I have these symptoms and I would like to get the monoclonal antibodies, or you could say that I would like to get the Regeneron treatment. And if their doctor is unable to get it, and I'm glad you bring that up, or unable or doesn't know how to obtain it, there's actually a website where you can find a local monoclonal treatment center. You can Google it, but also HHS has a monoclonal, which is the Health and Human Services website. They actually have a monoclonal finder. So I have a patient who's sick right now who's currently out of town. Normally I would order it for him. So I told him, go to this website, find your local center and go there. The good news is now most urgent cares should be able to at least set you in the right direction if they themselves aren't ordering it. Some emergency rooms carry it. So there are ways to get it. So even if your doctor is unable to help you, be proactive, be your own advocate, because this will really improve your chances of doing well if you get sick.
Got it. This is, I think, is a very, very important point that you made, because it is more of an education and awareness. So we have Dr. Yo here with us. He has a question. I'm asking these questions out of turn for Dr. Yo. I will charge him separately. So Dr. Yo says, is it true that niacin guy got suspended on Twitter? Can Dr. Parikh comment on that?
Yeah, so I only just learned this, that, one of the big proponents of niacin has been suspended from Twitter. I believe because he was kind of pushing things that were not evidence-based and which actually could be and were harmful towards patients. So, I don't believe in censorship, but if somebody is harming others, then, sometimes Twitter has to intervene.
Got it. Yeah, absolutely. And I earned $4.99 with that as well. So thank you very much for that too. Okay, so continuing our discussion for the acute COVID. So Cool Beans that are listening to this show, if you just could take that little clip of how to get the monoclonal antibodies. That will be an important lifesaver that you should have. So keep it somewhere with that time frame, or send it to someone, or take that clip out, or just remember that please keep monoclonals or polyclonal regeneral like things in your mind. So Purvi, back to you. What else? So
Mhm.
let's say here is the monoclonal antibodies. There is a concern that these antibodies can cause allergic reactions as well. So
Mhm.
number one, can you please talk about that? And number two, what other things do you do for acute management, acute
Right.
COVID management?
I mean, anything, almost anything can cause an allergic reaction. But the good news is with these, actually, the chances are not very high, because just the way that allergic react, especially if it's your first time getting it. And the reason being is the way allergies work and the way your immune system works is it's almost impossible. This is a big misconception. So I'm glad it's being brought up. It's almost impossible to have an allergic reaction the very first time you're exposed to something, because your immune system has to see it at least once to become sensitized or to become allergic. So many people think that if they've had something before, they can't become allergic to it, but that's actually not true. In fact, allergies develop that way. And then people will say, oh, but what about babies with food allergies? They've been exposed in some way, whether that's through their mom's breast milk. Believe it or not, there's, peanut allergen and just house dust. So there is some initial exposure. So the good news is, if you haven't had these Regeneron monoclonal antibodies, the chances of you being allergic to it are very, very low, exceedingly low. And the chances of it helping you fight the infection are very, very high. So I would still go for it. And so that being said, I wouldn't be so concerned. Again, the half-life, or how fast it leaves your body, current ones that are available within a month, half of it is out of your system, and then another month, another half. But I was actually told by one of the representatives of the company that they're looking into another monoclonal antibody preparation that might even last a whole year, which I think might be beneficial to some, especially those who are unable to get the vaccine for any particular reason, or if they get sick, it can protect them for quite some time, So it's very interesting, the different therapeutics we have on the horizon.
Got it. Thank you very much. So before we shift to in hospital management and then long COVID, I want to ask you a couple of more Purvi questions,
Mhm.
personal questions maybe. And
Okay.
number one, this is Dr. Yo's question. I'm taking lead from him. What is your spirit animal?
Oh. It's hard to say. I mean, I'm a Taurus, so it might be a bull. But then also, I like unicorns and dragons too. So I don't know. Can I have 3 spirit animals?
Absolutely.
2 of them are not real.
Got it. Perfect. And tell me, what is your bean title? What kind of a cool bean are you?
Oh, I didn't know. I didn't know I could have different titles. Are
You
there
could.
options, or
Absolutely.
like how? I mean, what type of
For
titles?
example, you could, Dr. Yo is the mean bean
Oh,
because right? So, or
uh,
Dr. Pierre Corey is coffee bean. So you
okay.
may be some sort of a bean as well.
So I think I would be the happy bean, because in
Perfect.
general I think I have a optimistic outlook on life.
Perfect.
uh,
I like it.
or
I
positive
like
bean, happy bean or positive.
positive bean is awesome. Yes. Awesome. So now let's switch to the COVID management. So in hospital management, and I
Mhm,
do not know if you have been working in the ICUs or you have seen or you have comment on that in
mhm,
hospital management, and then we'll switch to COVID, long
mhm.
COVID.
Okay,
So how do
so
you?
right. So
Yes.
in the hospital management, I haven't been treating patients in the hospitals themselves, whether it be in the ICUs or on the wards. So that I know is changing, and it's very, very different patient to patient, because no 2 patients come in with the same issues. So as we know, COVID-19 can cause a whole host of problems. It can cause heart inflammation, heart attacks, blood clots. So much of the management is directed towards what is occurring with that particular patient in that moment in time. So we know various treatments work, but it's not a one size fits all management by any means. Many patients, depending how they come in, may need steroids, to help fight the inflammation. As you know, COVID-19, it's not so much the infection, that's really deadly or causing all this havoc. It's all the inflammation that it brings with it. So steroids have been found to be very helpful. The antiviral remdesivir, and again, it's not in every hospitalized patient, ones that meet certain criteria, like if they're needing oxygen, if they're needing ventilator treatment. And then of course, because it's a clotting illness, because there's so many other issues that come along with it, you need to treat all of those. So blood thinners are very important and popular because to target that blood vessel inflammation. But then if there is a specific organ affected, then that has to be addressed. So I've seen it all. Like I know patients who've received lung transplants, patients who need dialysis or kidney transplants, patients who may need cardiac interventions. And of course, I can't speak to the details of all of these things because I'm not the one in the hospital treating it, but you just goes to show what we were saying before, this is a very, very diverse illness. So no two patients may have the exact same treatment. And on top of that, it's just, it runs the gamut. You have to treat what is specific to each patient.
Got it. Thank you very much. And now for the bigger topic, which I think the long COVID is becoming more and more prevalent as people are either exposed to it, some after COVID as a vaccine as well. There are some injuries to some who were infected. And as you were saying before, infected 2-3 months ago, and then later on they got a long COVID situation, and then it keeps relapsing and recurring. So tell us, what is long COVID and how are you managing it?
Right. So long COVID is basically the name given to those individuals who've, had COVID-19, recovered from the virus, and now months, and now we're seeing even years later, are struggling with some symptom. And this is no small thing. A recent study had shown that over 75% of COVID survivors have at least one symptom a year later, 6 months or a year later. And then, there's a large percentage that have many symptoms, and it completely has changed their life. People are suffering from brain fog, trouble concentrating on very simple tasks, just like watching the TV, right? Which doesn't take much work. That's difficult for these individuals. Memory loss. I saw a psychiatrist that said she wasn't even able to speak, find the words to speak. And this is a woman who has been talking to patients her whole career, and there's a lot of mental health disorders, even in people who never had one before. So anxiety, depression, even psychosis and schizophrenia. They're saying 1 in 3 COVID survivors have some type of neurologic symptom afterwards, which is really scary to me. So that includes everything from, the psychiatric illnesses to clots, strokes. But there's so many other neurologic symptoms that we still don't understand, but we see people suffering from. So that includes the ringing in the ears or the tinnitus, the loss of smell, taste. I know some people that still haven't got their taste and smell back, and they had COVID March of 2020. There's a lot of neuropathy, this feeling of vibrations in their body, and then just head to toe issues. So heart palpitations, heart racing, shortness of breath, stomach issues like nausea, vomiting, diarrhea. And these people have had $1 million workups done by every specialist. And for the most part, for many people, nothing is found. And those workups are appropriate because we don't want to miss something else, right? That's very treatable. But it's just what we're looking at, the working diagnosis is that even though the infection is gone, the inflammation that has stayed behind is wreaking havoc on the body from head to toe. And the reason why is what we're studying, so is it a persistence of viral proteins that's causing this constant cycle of inflammation? Is it an autoimmune disease? COVID is very much an autoimmune disease as it is an infection. So is there something that the body is now just overreactive to? Is it a combination of both? So time will tell. So I'm glad so much work and research outside of our group too is being done in this, because this is going to have a huge public health impact for years to come. Because everyone is like, oh, the death rate isn't so high. But yeah, everybody who recovers is not back to normal, and that means millions and millions of people are going to be suffering with this for many years, if not billions, who knows? So it's a big problem.
Agreed. And I sometimes think about it this way, that a whole generation, so all the generations that are together at this time in the population, a whole population has been damaged by this virus in some way. psychologically, physically, in this long COVID. There are
Right.
so many ways this virus has caused damage to this whole population, financially.
Yes.
So tell me this, Purvi, how do you? So let's say if I come into your clinic and I say, I have I keep getting this visual disturbances, or I get tinnitus, or I have some other, muscle fatigue, stiffness, or fatigue, or joint pains. How do you approach this, and what is the prognosis? What is your management style? When should a person expect to become better or not better? What happens?
Right. Yeah, that's a great question. So, what our group is looking at is markers of inflammation, or something called cytokines, that are staying elevated in these individuals months after their infection, or now even we're at the point where it's more than a year for some people. And what cytokines are is, they're markers in your immune system that help your immune system get ready, whether it be to fight an infection or do something else. So these are expected responses. So these cytokines, they go up with every infection. They go up every time you get a vaccine. They go up with, autoimmune diseases, even with allergies. So it's all things that are expected to turn on. But the problem is the immune system, usually, the cytokines go up, everything gets activated, and then it should come back down to normal. In these individuals, it's not coming down to normal for some reason. So what we're finding is they're persistently having elevated cytokines. And there's a whole host of cytokines that we're looking at, IL-2, 4, 6, 10, many of these that are high in even acute COVID-19. And I'm sure in the beginning, everyone was talking about that term cytokine storm. That is very deadly. That's kind of even an over amplification of it. And that is what is unfortunately landing many people in the ICU, and what they're having to combat, it's just a robust inflammatory response. But then we're also looking at cytokines that deal with blood vessel inflammation, such as VEGF, SCD40 ligand. We're looking at certain receptors like CCR5, which we know were involved in the HIV virus as well. And what we're doing is coming up with a targeted way to approach this inflammation. And if you have any of these elevated, we have been using different medications, again, experimentally, but they're all off-label use, to see if we can kind of target this inflammation and thus hopefully help these people feel better in terms of symptoms. So overall, I would say the prognosis is good overall, because we've helped many individuals kind of regain some normalcy back. It's a very slow and gradual process. It's not like flipping a light switch. It's more just like a dimmer, that slowly it improves, but it helps, because then at least we have something objective, and then we can say, okay, so your IL-2 and 4 are elevated. So maybe, a low dose of steroid might be beneficial to you. Or maybe we can do anti-inflammatory properties of ivermectin or colchicine. And if you have markers of blood vessel inflammation, maybe an aspirin or a statin can be helpful. So again, it's not a perfect method. It's not a guarantee, but at least now we have a guide and possible treatment protocols and possible medications that can help. And for many people, they are feeling better, and that's very rewarding.
Got it. So one more question before we ask Cool Beans their questions. And this question is my own curiosity.
Mm-hmm.
We give steroids, and steroids are general, anti-inflammatory and immunosuppressor, or modulating downwards. Why are the steroids not sufficient in this case? Why do we have to continue to add, let's say, other ivermectins or colchicines or statins or fluvoxamine, and still come back sometimes with not the healing that we were expecting? Why are steroids not useful or not as effective?
Yeah, that's a great question. And the inflammation from COVID-19 is very unique, I believe, because normally, me being an allergist, in that space, anytime you give steroids, it helps. And then especially when you give higher doses of steroids, it helps. But with the long haulers, we're seeing the opposite. Actually, people are feeling sick and worse with high doses of steroids. And it's actually the lower doses for more sustained periods of time that are helping them more so. Again, another mystery of this virus as to why the most traditional anti-inflammatory is not helping everyone. Even with Decadron, right, in the hospital, it didn't help every single person. It's only if you met certain criteria, because some people actually got worse with Decadron. So this is why we need to understand this type of inflammation better, because this is not your run-of-the-mill virus. This is not your run-of-the-mill inflammation, and it's very nuanced. So this is why we need to use other ways, other anti-inflammatory targets. The other important reason we need to use those medicines is because long-term steroids have so many side effects along with them, so we use them in our protocols too, but this is why the other agents are also important, because eventually we need to get people off of these steroids. We don't want them to develop bone problems or diabetes or weight gain, what have you. So it's very nuanced, and it's, again, another very complicated and complex part of this virus.
Got it. So thank you very much. I'm going to now, with your permission, I know that we are almost 1 hour. So please raise your hand. And if you are, short on time, if you can allow me to ask some questions. So there are some questions on Twitter. There are some questions here. So let's start from the live questions, and I'll shuttle back and forth. So there's a question here, and please feel free to pass on any question you like. Jean Olivier says, is there anything more you can share on herbs and COVID? I've been looking into it.
Yeah, I mean, that's an excellent question. I personally haven't been doing much research with herbs directly. That doesn't mean that they aren't helpful, but I unfortunately can't share too much on herbs and COVID. Again, I would just state that if you are looking into it, make sure whatever you're doing is safe and doesn't interact with any other treatments you're on for other medical conditions. But I apologize. There's so much research going into COVID-19. That's one area I'm not familiar with that well.
Got it. Thank you very much. Fair enough. Evok says, I think he's just talking about your profile here on Twitter. Jean Karenson says, question, what is the mechanism behind vaccines causing autoimmune diseases? I have multiple autoimmune diseases, and I'm so nervous to get the vaccine. If I've had 2 friends, each with an autoimmune issue, who got the vaccine and now months later have second autoimmune issue. Coincidence?
Yeah, that's a great question, and one that I get asked very frequently. So, the way autoimmune diseases work is basically there's something in your body that is causing a consistent cycle of inflammation, and then your own immune system starts attacking itself, or your own immune system creates what we call autoantibodies. So anytime where there's chronic inflammation, autoimmune diseases can occur, whether it's from residual from an infection or a virus or other reasons. But with the vaccines, the reason why I personally don't believe, at least from a scientific standpoint, that it causes autoimmune diseases is because the vaccine itself, the half-life of the mRNA vaccines is just 1 week. So that means a week after you get your Pfizer or Moderna shot, 50% of it is out of your system, and then 50%. So within a couple of weeks, it's gone. So just from an immune standpoint, it's not enough time for there to be constant inflammation in your immune system for that autoimmune disease to be created. Now, that being said, yes, the vaccine does cause a temporary state of immune activation, inflammation. It's supposed to. That's how vaccines work. So some people and that's why many of us, a day or two later, might get a headache or a fever or feel run down. We're not actually sick. It's all the immune activation. But what we found is that actually in those individuals with autoimmune diseases, it didn't make the autoimmune diseases worse, but it still was important for them to get protected, because many with autoimmune diseases are also on immune suppressive medications, which also puts you at higher risk, not just for COVID, but all infections. So you're kind of in this catch-22, because you have an overactive immune system. You potentially might be on medicines that could put you at higher risk for infection. So it is still in your best interest to get the vaccine so that way you can be well protected. Now, it shouldn't cause a new autoimmune disease, but sometimes it can increase inflammation. So in some individuals, you may have worsening of some symptoms, but it should not be permanent, at least from all of the data that we've collected now on hundreds of thousands of individuals. We're not seeing any new or permanent autoimmune diseases as a result. There were a few cases, not only with COVID vaccine, but also with flu vaccine of Guillain-Barré, which is a neurological condition, which is believed to be autoimmune in nature. And luckily, those are very, very few and far between. So from a statistical standpoint, you're more likely to be hit by lightning than to develop this Guillain-Barré. But this Guillain-Barré can be developed from any vaccine. So, we've seen individuals get it with the flu vaccine, other vaccines. So it's not so much specific to mRNA vaccines. And also, luckily, it's extremely rare. So I would still encourage most people with autoimmune diseases to get the vaccine. I've done so for my own family members. And again, like I never preach something I don't practice myself. I've taken it. I'm a young woman of childbearing age, and all my family members have taken it as well.
Got it. Thank you very much. There's a question from, come on, man. So the question is more about the effectiveness of masks, especially cloth masks, if children can actually wear a mask properly without gaps. I'm in Florida, where masks mandates at schools last year showed same results as school without mask mandates. Any comment on masks and their efficacy?
Yeah, I think masks are effective just simply from the barrier standpoint. So if I have something blocking my nose and mouth, and so do you, it's so much less likely that either of us will get each other sick. Last year, we can't go by data from last year. And the reason being is that there were no variants at that time, right? There was not variants that were infecting children, unfortunately, at the same rates that they're infecting them now. So that's why I would argue that, yes, I completely believe in kids going back to school, in-person learning. We've done a disservice in some ways keeping them at home, but I think for most part, I've never seen a child complain about wearing a mask. I treat children, actually. I have many children in my family. They're able to keep them on. So even if it's a cloth mask, there's still some benefit. Even if there's some gaps in it, there's still some benefit, because with the Delta variant, 1 in 5 cases is children. And many are getting very sick. So Florida, for example, Texas, the children's hospitals are full and the ICUs are full. And so, for me, even one child sick is heartbreaking. So I don't think we should just focus on numbers. We should just really look towards protecting kids overall, especially because many of them are very, very good with the masks. They understand that it's like a piece of clothing, just like their shirt or their pants or their shoes.
Got it. Thank you very much. Jean M. Oliveira says, histamine. What role do you see histamine and antihistamines are playing in treatment of active COVID, in treatment for long haulers, and during the vaccination process?
Yeah, that's a very interesting question. So, I think there is a role of histamine. And the reason why that is the case is that I noticed that many of my patients who got sick with COVID-19, early on, that were on certain biologic medications that they take for their asthma or for their eczema, that actually reduce histamine levels in their blood, they did really well. Even if they had very bad asthma, they still got sick, they were suffering, but they stayed out of the hospital, they stayed out of the ICUs. So I think there is a role. And many of the long COVID patients do also express that they feel significantly better with antihistamines, and they weren't patients that necessarily suffered from allergies or asthma prior to getting sick with COVID-19, but they're doing very well with things like Zyrtec, Claritin, Pepcid, which is another histamine blocker. So we are in the impression, I do believe that mast cells are playing a role in both active COVID and long haul COVID. And it's funny that you brought up a thing with the vaccine. I can't explain it, but there are some individuals that I've seen who've had issues with the first dose of the vaccine. So I've actually pre-medicated them with the second dose of the vaccine with Zyrtec. So I don't give steroids beforehand because I don't want the steroid to make the vaccine ineffective, but I'll have them take Zyrtec 12 hours, 7 hours, and 1 hour before. This isn't evidence-based protocol. This is just Purvi protocol. And they've done very well. And I can't fully explain it. It had less side effects. I've also had them hydrate well. So there must be, I think there is some component to it. And the immune system is a very nimble organ. It's very nimble. It's very complex. So it's not that each part is a separate island. They all work together. So, mast cells play a role in allergies and asthma, but we find mast cells even in cardiac tissue when someone's having a heart attack, right? So we know they're important for other types of inflammation as well.
Got it. Thank you very much. Very, very useful points. Carol Robert 45 says, monoclonal antibody infusion, Regeneron, if you have Hashimoto's, thyroiditis, and thyroid eye disease, IV infusion versus subcutaneous. So can they take, if they have Hashimoto's or thyroid disease, can they take monoclonal antibodies?
Yes, they can, because these antibodies are very different than your thyroid antibodies. So there's no interaction that it would be harmful for you or make your thyroid disease worse. So absolutely, if you get sick, I highly encourage taking them. In terms of subcutaneous versus IV, either. I love subcutaneous because it's easy to administer. You don't need to start an IV if someone has bad veins or is dehydrated. So I'm a fan of subQ just because of the ease and convenience of it, but either is good.
Got it. Nightfall X66 says, what is the current theory about what causes the rare paresthesia, dysautonomia, and other neurological like symptoms in post-vaccine individuals?
Right. Yeah. So that's a great question. And another one, again, that we're looking into. I mean, I do believe that it is related to inflammation and immune activation. But to be frank, we don't know. This is another thing. Like, you have to understand, in this pandemic, we're building the plane as we're flying it, right? So we're learning just as much as everybody else is, but it definitely is some immune component or inflammatory component. But the good news is almost everyone who I've seen with the tinnitus, paresthesias, and other neurologic symptoms, they do resolve. Many resolve even without treatment too. So I have a colleague who did have tinnitus for almost 2 to 3 months after her vaccine, but it self-resolved. So again, the good news is that it doesn't appear to be permanent or long-term.
Got it. Bambi Secret says, would any particular antihistamines work as a prophylaxis if taken long-term?
Okay, that's a good question. So it wouldn't work as a prophylaxis to getting ill, but it would work as a prophylaxis, let's say, to the symptoms that come along with the infection. But I wouldn't rely on the antihistamine alone, to protect you from COVID-19, because unfortunately it doesn't have any infection properties. It more helps with what comes with the infection, if that makes sense. So it won't protect you from COVID-19 or any other virus. I have patients on antihistamines 365 days a year, and they still get sick with all the same bugs everybody else does, and with COVID. So I wouldn't rely on that to be the only thing, but it might help your symptoms after the fact.
Got it. Thank you. Ronnie says, what is causing the foot and toe pain, and new ideas how to treat it? Lots of people suffering ongoing COVID toe problems and peripheral coldness and pain. Is vascular inflammation behind it? And do you think Bruce Patterson theory fits the symptom?
Yeah, that's a great question. Yeah, I think it is. Much of it is related to vascular inflammation. Some people have postulated that it could be even like micro clotting in the vasculature of your fingers and your toes. Luckily, that too is not like dangerous in the sense that you don't have to. It's not like frostbite or something where you have to fear that your fingers will fall off or your toes will fall off. Many treatments do focus again around anti-inflammatory medication. So I know some of the dermatology colleagues will start with topical anti-inflammatories like steroids, topical hydrocortisone. If that doesn't resolve, I would encourage that you see a specialist, though, to get more in-depth treatment, because, we do believe that it's all vasculature related. But even outside of that, there's rashes with viruses in general are very common. So we frequently will see hives, other rashes that appear almost like allergies or other etiologies from any and every virus, because the virus can stimulate your immune system in the same way that an allergen can. So some of the redness too from the COVID toes and fingers, yes, some of it may be vasculature related, but some of it may just be immune activation, what we see with other viruses as well.
Got it. Thank you very much. Janet Elderton says, How is the rollout of COVID long haulers going in Spain?
Oh, in Spain. Okay. Yeah. So, I mean, it's in process. We're not ready to go quite yet, but I know Dr. Patterson and Dr. Yogendra have been working very hard to kind of get that lab up and running, and as well as, hopefully getting physicians there in place that can be part of our program. But stay tuned on more details from that.
Got it. Thank you very much. Do you have a few more minutes to ask some more live questions from the YouTube side?
Sure. Yeah, I have a couple minutes, then I have to run because I have some patients waiting. So.
Okay, so I'm gonna just a couple of questions then. Soma and Sirjoy Ghosh says, within how many days adenovirus vector vaccines are cleared from body completely? Is there any long-term side effect issues after vector vaccine few months later?
Oh, that's a great question. So the vector vaccines also are cleared very quickly from the body. We actually have a lot of, we have more experience, with the vector vaccines even than with the mRNA vaccines, because we use it currently for Ebola. And that research has been ongoing for over 80 years. So longer than, most people who are probably watching this chat or have been alive. So that's great news, because then we have that 80 years of experience to see if there are any long-term effects, if there's any persisting effects. And the good news is overwhelmingly there are not. And that's why so many countries have used the vector vaccine. The nice thing about it is that it's very easy to make. It's easy to modify if there are variants. So, Russia is using it, most of Europe, we're using J&J. So overwhelmingly, we have a lot of data, even more data than mRNA vaccines, on its safety, efficacy, and lack of long-term issues.
Got it. Thank you very much. Last question. Augie says, have any long haulers, COVID long haulers, resolved completely?
Yes, absolutely. So I'm happy to say many have, some without treatment. A close friend of mine had, luckily after a year, she just turned the corner. And I know others through our program have either resolved or come very, very close to resolution. And that's very gratifying when people are like, oh, I'm 80, 90% better, getting back to my normal life. And then some individuals are lucky in that, ironically, the vaccine has helped them. Not all of them, so we can't really predict who it will work for. But there was a big article in the New York Times a few months back that some people were lucky that within 1 or 2 doses of the vaccine, they resolved, and I think that may go with that viral persistence theory, that maybe that vaccine is helping clear out residual protein. So not everyone, I know some feel worse after the vaccine, but we have seen resolution, and in all 3 groups, by doing nothing, by the interventions we're doing, and some, with the vaccine.
Got it. So thank you very much, Purvi. Thank you for your time. Thank you for the insights. I think one of the most complete set of insights I think your background as an allergist, immunologist, and then with COVID, and then the vaccine research, that all is a great fit to serve at this time. So thank you very much for your time and insights.
Thank you. Thanks for having me.
Hopefully we'll have you again to ask more questions about immunology and other areas. So thank you very much.
All right. Take care. Bye.